Okay. So today my presentation is going to end up being about sickle cell disease, but I feel like I should walk you through how I came to this because it's pretty interesting.
Pick a chair.
Yeah, come sit down, Tom. So I actually started off by looking up every year the Cleveland Clinic posts a news article about what they think the top 10 medical innovations for the upcoming year will be. And sometimes it's hit or miss, but usually they're pretty good. So I looked up their list for 2021. And a lot of them are fairly COVID related, so things like telemedicine. But number one is genetic treatments for sickle cell disease. Because I have a background in some sort of related technology. So before I get into that, I thought you might want to see the full list of what they think the top 10 medical advances for 2021 will be. So other than sickle cell, there's also some novel drug therapies for primary progressive MS. Smart pacemakers, so those are literally pacemakers that will connect to your smartphone and you can adjust them, you can transfer data, which also apparently has the connected research topic of security in pacemakers, because people can hack into your pacemaker and make adjustments.
What?
Not good.
To kill you.
Although apparently you can already do that with current smart pacemakers, even though they're not as smart as.
But does that exist for defibrillators? Because if that's the case, then I can just shock you, right?
You know, I don't really like this patient.
This patient has come too much to the office.
Very combative. Give him a shot. Also, some new cystic fibrosis treatments, universal hepatitis C treatments, which is a big step. Bubble CPAP in premature babies, increased access to telemedicine, like I mentioned, vacuum-induced uterine tamponade devices, PARP inhibitors for prostate cancer. And this one's interesting because there are PARP inhibitors that they've previously used in women for different cancers, but this is the first time the FDA has approved PARP inhibitors for men. And then also immunologics for migraine prophylaxis. So I looked at this whole list, and initially I thought about maybe going through and doing a little blurb for each thing, and then I realized how many things that is and how in-depth you can get. So I decided to concentrate just on hemoglobin alpha. Are we not? Our picture's not showing up?
This is comfy.
Okay, only that picture didn't show up. So specifically, the things that are coming out this year are for beta hemoglobin. So that includes beta thalassemia, sickle cell disease, which is good because those, or the most common of those, sickle cell and beta thal, affect 300,000 children born every single year in the world. And there are several trials from different companies that we'll go over later. Those include Bluebird Bio. You might have heard of Bluebird before. It's kind of big in the LA region. They've come up with a bunch of kind of paradigm-shifting medical technologies. And then CRISPR Therapeutics, which I think was founded from the group that actually created CRISPR-Cas9, which makes sense. And then Vertex Pharmaceuticals, which also uses the CRISPR-Cas9 system. So to give you some sickle cell basics, hemoglobin is usually soluble within the red blood cell, and it doesn't polymerize. But if you have a very specific mutation from sickle cell, which is the blue 7-billion mutation, which is just a GAG to a GTG, so it's a point mutation, it gives hemoglobin S, which is what is called then the ability to polymerize under certain stresses. And that actually forms these long intracellular fibers that can then contort the red blood cells into different shapes, specifically the sickle is more common. And the insult that most commonly causes this to happen is deoxygenation, although other like physical insults can cause it. And this new shape results in intravascular and extravascular hemolysis, increased adhesive interactions with platelets, white blood cells, epithelial cells, all kinds of stuff. And also reperfusion injuries, inflammation, and vessel blockage. With vessel blockage being probably one of the things that you see the most often in the hospital, because you get what used to be called sickle cell crisis, but is now called I think a vaso-occlusive crisis, or there's another term that I'm forgetting, which can result in between mild and extremely severe pain for patients. it also results. This is an interesting fact. Hemolysis also results in free hemoglobin floating in your blood vessels, and free hemoglobin is a nitric oxide scavenger, and so you actually get remodeling of your vessels, changes in the vasculature based on deficits in nitric oxide. I also thought this was an interesting fact. They did a study in 2018 where they identified, basically they worked backwards through the genomics and found that there was a single mutation in history that causes sickle cell disease, so it didn't occur multiple times. One person had this mutation way back, like 7,300 years ago in the Holocene era. And this was when it was still really wet in parts of Africa that are now desert, so that the Sahara was green at this point. Very tropical, lots of mosquitoes. And so the reason that this mutation was probably carried on to as widespread levels as it is that a single mutation helps you with malaria. So even though the double mutation is bad and causes sickle cell disease, and you can die young from it, having one mutation is good for survival, and so it was carried on to the population. So one thing I didn't know about sickle cell disease is that there is an extremely wide variability in phenotype. It's influenced by lots of genes and the environment. So things in the environment that you should look out for are air quality, tobacco use, carbon monoxide, nitrogen, and particulate matter, and increased production of fetal hemoglobin with certain modifying genes, or if you have alpha thalassemia, or it can actually inhibit polymer formation. So that was important because those were some of the original targets for therapy. We're seeing if you could get someone to promote their fetal hemoglobin, and that would block the sickle cell variant of hemoglobin, at least from polymerizing. Also, decreased cell density. So alpha thalassemia apparently causes a decreased density inside of the cell, and that can decrease hemolysis. Altered levels of 2,3-BPG, and I'm not going to try and say the whole chemical name for BPG, changes oxygen affinity, and because that differs from person to person, and because, like I mentioned earlier, deoxygenation is one of the things that can cause polymerization. So the different genes that people have for 2,3-BPG can affect how much sickling occurs. Dehydration is a huge factor. So if you are really dehydrated, it takes a lot less deoxygenation for polymerization to occur. And so you always want to make sure your sickle cell patients are hydrated. And then any kind of damage, as I mentioned, circulating plasma proteins, and particularly cytokines. So either with something like infection that affects cytokines, or just your natural cytokine rhythms can cause you to have a worse phenotype. And then I mentioned NOCAP. So diagnosis. I was taught back in college that it was gel electrophoresis was kind of the way you do it, but apparently now it's actually HPLC is how you diagnose sickle cell. One thing that I didn't know as well is that you can't really diagnose it for sure at birth. The fetal hemoglobin tends to hide sickle cell hemoglobin, but it's actually so severe in most people that within 3 months you start having hemolysis, and then within 4 months, within 3 months you can start seeing sickled cells, and then within 4 months you start having hemolysis. And so one of the things that also shocked me was how common it was in California, because the genetic trait occurs in 1 in 75 babies born in the state of California. And particularly at risk are African Americans, which I think is pretty widespread knowledge, but also the Hispanic population is really at risk for beta thal and for sickle cell.
Really?
I know 1 to 75 was kind of a shocking number for me.
That's a lot.
That's
categorizing both of them together.
Yes.
Or is it sickle cell?
Genetic trait for sickle cell disease or beta thalassemia is 1 in 75. So like I said, HPLC is the gold standard now. It's really very highly sensitive and specific, or specific, depending on how you're feeling that day. And it can be automated, which is one of the reasons that it's the gold standard now. And it determines your hemoglobin variance based on retention times. The one problem with it is that it's very expensive. And so it's the gold standard because in places like Europe and America, you basically just run this machine automatically, test every baby that's at risk, get your results quickly, and they're very specific. But you can't really use this in a lot of other countries that can't afford HPLC technology. And so they still do use gel electrophoresis. But there's a new technology that's hopefully coming out soon, and it's pretty wild. It's a paper-based test that obviously much cheaper, that they think will be not as specific and sensitive as HPLC, but specific and sensitive enough that if, say, you take it out into a country that doesn't have good testing, it should really help. Also, I do want to tell you, if you were taught on the Sickle Dex system, I don't know if that sounds familiar to either of you. So there's an old sodium metabiosulfate test, which I think we're also taught in medical still.
Historically.
But up to date, made very clear that there is never an indication to use this test anymore, which surprised me because that was one of the things that I was trying back in college. So apparently we're moving in the future. So there are both acute and chronic manifestations of sickle cell disease, and I wanted to concentrate on this because if I did beta thal as well, it would get a little confusing and also be an hour long. And so some important acute sequelae are infections, severe anemia, and then vaso-occlusive phenomena, which includes the whole umbrella of sickle cell crisis. That's when you have small vessels that are blocked and cause intense pain, stroke, acute chest syndrome, renal infarction, dactylitis or bone infarction, MIs, priapism, venous thromboembolisms, or pregnancy complications. And then for chronic, and I'll go over some of the most important here a little more in depth. For chronic, you can have just general pain, anemia, neurodeficits or seizures, pulmonary conditions, including pulmonary hypertension, which is related to the NO again, renal impairment and hypertension, osteoporosis and complications of bone infarction, cardiomyopathy with diastolic dysfunction, hepatotoxicity, and one of the big sides to hepatotoxicity is because so much of this is treated with blood transfusions. What you're looking for with hepatotoxicity is actually iron overload. Gallstones, delayed puberty, chronic leg ulcers, and proliferative retinopathy. So, one of the things that UpToDate also made clear was that we are no longer calling sickle cell crises. That's the old terminology because they're not always a crisis. So the new terminology is acute painful episodes, which pretty much describes what they are. And they can be either just pain with no effect, or they can mask other complications. So you always have to work them up a little bit. And they occur in up to 1/3 of sickle cell patients daily. So they're very common, but with varying severity. They're also, UpToDate said, the most common reason that sickle cell patients will actually come into the hospital, and so it's good to have some kind of background in recognizing them. Pain can occur in your back, chest, abdomen, extremities, and then in children, the most common is fingers and toes, is dactylitis. One of the other things that it made really clear is that the absence of hemolysis on an exam or on test, or a stable hemoglobin, is not a good justification to not give pain medication.
It doesn't correlate with pain?
It doesn't correlate with pain, and also specifically because of the populations that this is most common in African American and Hispanics, who are generally less likely to get pain medication when they need it. I think that there's a big problem with physicians'
judgment or
basically
bias
under prescribing pain medication.
Absolutely, yeah.
So UpToDate had a very good section that was the only thing that you need is the patient report in order to prescribe for these patients. You don't need to go looking in labs to go, okay, well, do I see anything? So that was nice to see that UpToDate. And so there are a couple mainstays of treatment here, and I tried to give some specifics just in case Dr. Oliva was in the room and wanted some dosages. But the main therapy is Hydroxyurea, which is actually like long-term treatment. And in children and adults, you can give this medication. In children, you want to start with 20 milligrams per kilogram a day, and in adults, it's 15 to 20 kilograms. And then renal dosing is super easy. It's you basically take the dose you wanted to give and cut it in half. And the way that works is that it increases the fetal hemoglobin that I mentioned a few times,
He's gonna be happy.
and also nitric oxide.
Yes.
It affects the RBC rheology, decreases white blood cells. Basically, it just makes it less likely to have hemolysis and polymerization. And then also with hydroxyurea, some concurrent treatments that you can give, not all of them, but one of these is
So he
L-glutamine,
can follow the dermatologist.
crizanlizumab,
You know how
and
many days I should
voxelotor. And there was actually a recent study for the voxelotor, which I hope I'm saying right, called the.
Can you
How about the polysporin like the situation?
I know you love these studies with the name Dr. Chang.
Do you want me to come back?
Oh no, you keep talking and I'll start finding that.
I'll give you this as well. So
What's the
there's-
name?
It's called the Hope Study.
Sure. I get that one.
So
Thank you
music
for
will
the
find
information.
names. This is from you.
Yeah.
You have to catch your name. It's important.
Yeah, you gotta have
Thank
those
you,
catchy
Dr.
names on these studies.
Hey.
But basically, it found that it decreased symptoms, but it didn't actually change clinical outcomes in like what was it, 24 months?
I need a pen.
So they didn't have vaso-occlusive crises, or they had fewer vaso-occlusive crises, but there are no improvements in clinical events at 24 weeks. That was weeks, not months. And then some important things to remember about hydroxyurea is that you should discontinue it only if you have cytopenia, kidney damage, cutaneous toxicity, pancreatitis, or you're planning to conceive. And interestingly enough, with hydroxyurea, the conception applies to both male and female patients. You don't want the father taking it from the and then the other mainstay treatment with pain crisis, or pain episode, acute pain episode, is oral opioids, which you just dose as per pain level. Another very important thing to know with sickle cell is that they have infections often because they have functional asplenia a lot of the time. And I didn't realize how early that can occur, but by 2 to 4 years old with the sickle cell treatment, they've already had an autosplenectomy much of the time. And also, aside from the asplenism, they have reduced tissue perfusion, which affects white blood cells, all kinds of other things with infection, and then hypoventilation. And so bacteremia, meningitis, and pneumonia are three of the things that are more common with sickle cell patients, and particularly from a couple of organisms, especially encapsulated organisms, because of that functional asplenia. With bacteremia, the most common thing that you see would be strep pneumo and H flu. You also see E. coli, Staph aureus, and Salmonella. With meningitis, again, you see strep pneumo, H flu. But one of the important things, because stroke is another of the things that sickle cell can cause, is that you want to make sure that you distinguish meningitis from stroke.
I think it's the most common cause of stroke.
Wow.
And then,
In pneumonia, you have mycoplasma pneumonia, chlamydia pneumonia, and legionella are the most common causes of sickle cell, rather than the more common causes of pneumonia. And so the empiric treatment, according to UpToDate for fever with sickle cell, is ceftriaxone IV. And then if you have meningitis, you would add vancomycin. And then if you're allergic to cephalosporins, you would do clindamycin. And then another important thing to note is that one of the big steps with sickle cell recently is first of all, continuing penicillin prophylaxis, but also because of vaccination rates for pneumococcal vaccines and H flu, both of those things have been really plummeted. And then, so my last important component I want to talk about anemia. Pretty self-descriptive for most of the time. There's a lot of hemolysis, but some of the important things that you should know are that all sickle cell patients should have supplemental folic acid. Also, when you're monitoring anemia, obviously you need to establish a baseline for anemia, and then monitor for iron stores and iron deficiency, because you don't want to transfuse a patient if they're already got the iron overloaded. And then the last thing that I didn't go too much detail about, because I think we all learned about it in med school fun facts section, is aplastic crisis. With sickle cell, you have to be worried in kids with a parvo B19 infection that they can that's also managed by primarily transfusion.
Yes.
So this is the thing I was actually working up through all this stuff to talk about. Even though there's not very much information publicly available about it, is the new treatment possibilities. So there are actually a couple of directions that things are going. Bluebird Bio, the company that I talked about earlier, one of the things that they're looking into is a lentivirus vector. The lentivirus is related to the HIV virus sort of remotely. But it's used by a lot of laboratories because we'll use it on cell lines to add genes that we want to test. And so they had said that they believed that they had a good lentivirus that they could replace the bad hemoglobin gene, or they actually had a couple of things that they were testing. They would either replace the bad gene with point mutation with one that didn't have point mutation, or they would put in a different whole hemoglobin gene that basically prevented hemoglobin S from being either transcribed or polymerizing as easily. And I'll get to that. CRISPR Therapeutics, they're just using CRISPR as you could probably guess from the name. And basically what they would do is go in existing cells, cut out the point mutation, and put in the gene sequence that's supposed to be there. And then the other option that people are looking at separately is knocking down the BCL11A or the KLF1 gene. And these are all genes that kind of regulate fetal hemoglobin expression, because fetal hemoglobin, when it's expressed, can either lower the expression of hemoglobin, the beta globin in general, and so therefore you have less of the sickle cell globin produced, or it can be produced concurrently with it, and it prevents polymerization. So the lentivirus vector, this is Bluebird Bio. Basically what they do is they would actually take hematopoietic stem cells out of patients, and then each patient's individual line would have the lentivirus injected, a corrected beta globin, or an anti-sickling hemoglobin A gene would be injected. One fun fact about this is that the Cleveland Clinic's list came out in November, and as of January, Bluebird Bio's study was paused because they had multiple patients that developed leukemia, which was then determined to be due to the study and not just chance.
Oh, wow.
And it does make some sense. You're messing around with some hematopoietic cells, you're injecting DNA. And they had one participant that had acute myeloid leukemia and then one that had myelodysplastic syndrome. This is after they had several patients that had myelodysplastic syndrome that they said were not due to the study. Now they're looking back at those patients and saying, there's the potential that it was actually caused by the treatment and not something else like they said. So this study is on pause right now. CRISPR, I could spend a week just trying to explain it. We could all try and figure out CRISPR together, so I put up a graphic here that explains it in pretty broad strokes, which is basically that you have a guide RNA, and the CRISPR-Cas9 system uses that protein complex, the Cas9 RNA complex, and it goes in and it has specific markers in DNA that it can edit next to. And so luckily, sickle cell is one of the genes that has a marker that's at a good location to edit for the point mutation. And so the CRISPR-Cas9 complex goes in, cuts that out of existing cells, and puts in the correct genetic sequence. And so you don't have to have any viral vectors, basically just fix the DNA that's there, which is
Wow.
And I didn't put any
I know.
specific numbers in here for their. I didn't put any specific numbers in here for their newest study stuff because they're only just releasing some data, and a lot of it is more like hearsay than official papers. But the latest was basically as soon as Bluebird Bioventures had problems, CRISPR Therapeutics said, we're not having any problems. We have all on target edits so far. They were saying that like 80% of the genes that they targeted were correctly edited so far, which I don't know what that measure means because they didn't give any good numbers behind it. So 80% of stuff they tested. So results overall were actually very promising, even in the Bluebird study before it was paused. They had in one study where they introduced hemoglobin A gene that they call the anti-sickling hemoglobin A. So it's produced alongside the hemoglobin S, but prevented it from polymerizing. They said that they had about 40% of hemoglobin at the 6 months follow-up was made up of hemoglobin A, which is pretty remarkable that they were able, and this is just from a random blood draw throughout the entire body, that they were able to get 40% of hemoglobin to be their injected variant. And that resulted in a 99.5% reduction in vaso-occlusive crises, or ACS, in patients that previously had a history up to the 6-month mark. And then when they looked at it again at the 24-month mark, they had no major vaso-occlusive crises or ACS events. One aside here for both of these studies is that the initial study was very small, 16 to 18 patients. They have a much larger study going now. The problem with seeing numbers there is because Bluebird paused the larger study, things are a little bit harder to find. I think they don't want people to see information right now. For CRISPR therapeutics, they have a whole series of studies. They're all called CLIMB, like 1001, 1002. There's a bunch of them. So they have kind of different measurements for how successful each study was, but some of the highlights are 7 patients that were previously transfusion dependent. So, they had to survive basically by getting transfusions fairly regularly, became completely transfusion independent. I think 3 of those patients had either the severe or the B-null phenotype, which is the worst thing. Right? No, that's all 4. Right?
Oh, alpha had 4. Never mind.
And so the B-null is very severe, but they were able to go transfusion free because of this treatment. And then the 3 patients that previously had sickle cell, because this is for beta thalassemia, the 3 patients that had sickle cell disease were free from vaso-occlusive crises and follow-up. So, fairly impressive results early on. So, let's see what I have for you guys today. Hope for the future.
How are they editing? What are they?
How are they editing which part?
What DNA are they going to achieve? Like, how are they doing that?
So that's the interesting thing, is because there are, CRISPR-Cas9 is fairly.
It says KLM1, something like that. I
So
can't
that was
remember.
one of them. Okay. It's confusing because there are so many genetic targets that they're going for in all these different studies, and as I said, CRISPR therapeutics, they don't just have one strategy, they don't have one study, they have a whole bunch of things they threw against the wall to see what would work best. Even Bluebird had 2 different strategies, one where they would have basically an anti-sickling hemoglobin A, which is where they inserted a whole hemoglobin A gene that had some modifications to it that basically it interacted with the beta hemoglobin sickle variant in a way that kept it from polymerizing. Right, so usually the beta hemoglobin will stack with just beta hemoglobin, and then alpha hemoglobin doesn't interact at all. So they modified this alpha hemoglobin so that it could block that polymerization, interact but not be able to interact with the next unit in the chain. Does that make sense? So that was one strategy they had. The other was to go in with a lentivirus and try and fix the beta hemoglobin itself. And they don't have any numbers for that study, so I feel like it was either less than successful or still in progress.
So they irradiating people, wiping out the bone marrow and then starting fresh.
So one of the reasons that the specific Bluebird study said that they had myelodysplastic syndrome was because they thought that it was due to the radiation of originally ablating the bone marrow, although apparently not. So for some of these studies, yeah, you have to fully wipe out whatever they have. For the CRISPR therapeutics, I'm not as sure that they have to do that. I didn't see anything saying that. But yeah, for CRISPR, basically they're going into the actual beta hemoglobin gene and swapping out the point mutation. They can go ahead and cut out that segment only and replace it with what that's supposed to be there. And then for these other studies, which I don't think I put up any numbers for. What they're doing is going in either changing the promoter of some of the genes, so like fetal hemoglobin, so that it's produced, it's not supposed to be in adults at a high level. So they're trying to change the promoter so that it is produced, and that can also interfere with the sickling, with the hemoglobin, beta hemoglobin sickle variants.
Any other questions from anybody else?
No, sickle cell is always intriguing, and it's more of an art than pure medicine, because you have to, like you said, if the patient reports it, you have to treat it, and we see it all the time. It's the classic patient that you will judge for his for his choice of using opioids or requesting opioids around the clock every 2 hours, high dose of Dilaudid because morphine doesn't work, and then you check their cures report, and they are taking Norco here and there, or Dilaudid here and there, and you see so many providers giving the same. So it's easy to say, I don't trust you, and I'm just gonna keep you on low dose morphine and have this patient suffering. So it's still, even, I don't know. I think I'm excited about the point of care testing, because if that's the case, as you said, it may not be very sensitive, but it could be very specific and give us an idea. Okay, okay, I trust you. You have sickle cell disease, and I'm gonna give you all the pain medications, all the time you need to recover. Because one of the problems we have with these patients is that they complain of so much pain that even if you hit them hard with fluids, with pain medications, it takes 5, 6, 7 days to get them out of the painful situation that they're going through, and it's hard to believe. And a lot of them get the label of addicts, and actually they're actually suffering.
Well, I think it's important again to note that up to date made it very clear that there's no testing that can correlate the pain.
Exactly, and that's another thing, that a lot of them get this label because their blood work shows normal, not even a little anemia, or sometimes just mild anemia, and then people think that it doesn't correlate. There's no hyperbilirubinemia, so there's no actual sickling, and this patient is lying, and send him out.
I'm very glad that you brought it up, because one of the things that I used to do is I'll admit these patients to county hospital, and if their hemoglobin is better than their baseline, then I think, they could be in crisis. And if their hemoglobin levels are way lower than their baseline, then I think it might not be. It's one of those things that just sort of told us the correlation. Oh, maybe there's a correlation there. I can just use that as a surrogate. You're telling me there's no such thing. So I'm glad you brought it up.
And then you get to the social aspect of this. You're saying that this is happening a lot on minorities, right? So it's happening a lot of minorities, and minorities are patients that don't have good access to medicine, right? To the proper care that they need. So guess what happens to the young Hispanic patient that lives in the streets and doesn't have time or transportation to go to see a doctor or money? His first choice is going to be using methamphetamine or marijuana to try to decrease the pain, because they are in pain, and somehow they have to numb it somehow, and that's how they get into one hole to another one.
Can you guys imagine, just having these people coming in for pain and think they're drug seekers and realize after the fact that there's sickle cell? Shit. I'll be back. But hey, there's a couple things I want to start out by saying, which essentially it boils down to. I already told John Oliva that he should have been here to listen to you. But you can tell that there's a slight difference in preference in regards to where to focus your presentation. You notice he's talking a lot about the underserved community and testing and things like that. From our discussion in the past, I always end up talking about the latest and greatest new device so that you guys can treat me to a nice dinner somewhere. But no, seriously, I do appreciate that you targeted towards me and showed all the nuances and stuff that's going on. I'm not certain if you intentionally did that, or if you just read it, the top 10, and said, oh, look, that's interesting. I appreciate it, because I didn't know anything about all of this. Now,
I didn't know anything about that either.
Formally speaking, I have to state that this probably could have made its way towards the hematology ground rounds in the internal medicine residency program. So good job on your presentation. I'll admit, I feel like I unfortunately have been showing you guys somewhat more trickier presentations with all sorts of information that are pulled in, so therefore you decided to make it to this level. Sorry, man, you must have spent a lot of time. I appreciate it. If you have a chance to, if you ever go to hematology, I swear to you they'll be interested to learn about these kind of stuff.
I'll save this one on my computer.
Yeah, absolutely. Seriously, present it to John. If you ever go to HEMOC and you want to talk about this, just say I did some research into this, you might be interested. See if you can present it. Because I honestly feel like that's the level of where you are with this presentation, okay?
Good job. Thank you.
Thank you.
Yeah.